Hello, everyone. We see you. We see all of you online. I just wanted to give you an update. We're going to start in about 5 minutes or so. Give a little extra time. 5 minutes. Oh.
Turns it on.
All right. Welcome, everyone. Thank you for coming. It's a good night to be here, don't you think? Well, tonight we are doing our Meet Our Experts Live. We have Dr. Casey Kelly, who is going to be presenting about palliative care and what it looks like to live a really good life, even when you have a serious illness. I'm super excited about this. Been looking forward to it for a while now. So, Dr. Kelly is from Florida. He's come and joined us. Been here since, has it been October, July? Okay, well, July, and has been a really exceptional member of our team. I'm super excited to have him, and I'm going to give it over to him. You ready? Oh, couple housekeeping rules. Thank you. At the end, we will open it up for questions. If you have questions for Dr. Kelly, you're more than welcome to ask them. We just ask that you use these microphones on the table. You're going to, at the bottom, it says push. Just make sure you push that and talk kind of towards it. So then that way everybody can hear the question. And if you forget, that's okay. I might give you a little reminder. Everyone online, if you have a question, feel free to submit your questions in the chat box and we will get to those as well. The one thing I'd ask is if you would think about the kind of question you're asking. You want to ask questions that refer to something that everybody should know and not necessarily specifics about your own health care. As much as we want to know those things, that would be a great opportunity. We can make appointments with Dr. Kelly and set up time where you can talk to him yourself about those things. So without anything else, here you go, Dr. Kelly.
Test. Working okay? Okay. All right. Thank you all for being here. And for those online, I really appreciate it. And I'm sorry for any NFL fans who are missing the NFL draft right now, myself included. I will, hopefully you guys can catch the later parts of it. But thank you so much for being here. So I'm Casey Kelly. I'm a palliative care physician. I've been here since July. I'm originally from Florida. Spent most of my life there. I did medical school in Alabama. Did all 4 years of my medical training in Florida. I was ER trained, so I'm boarded in emergency medicine, and I also did training in hospice and palliative care. So that's a little bit about me. And I love being in Flagstaff. People always say, oh, Florida, that sounds like a downgrade to go from Florida to Flagstaff. And I'm like, no, it's actually the opposite. I love it here. I love the cold. And it's been a great experience so far. All right, so some learning objectives that I'm hoping we can accomplish today. So first off, understanding what palliative care is and what separates it from different specialties, because palliative care in my experience is quite different than the traditional sort of usual way of medicine. Know the differences between palliative care and hospice. I know among the public that people kind of use the words interchangeably, but there are some pretty big differences between them. And lastly, understand the value of palliative care in advanced disease states. So first off, what is palliative care? So palliative care, I describe it as a philosophy. It's a philosophy that focuses on several different things. And one of those things is, first off, it provides support for you and your family. Okay, we have more time to spend with patients and families during our appointments, during our interactions, sometimes going for an hour, hour and a half. We want to get to know you, not just look at your chart, not just look at your labs and numbers. We want to get to know you as a person. And so palliative care provides an extra layer of support for you, your family, your loved ones. Palliative care also is very big on symptom management, managing complex symptoms that may come from your condition itself or from a side effect of the treatment for that condition. So an example would be a patient who has cancer. That patient may have pain from the cancer itself, but they may also have side effects from their treatments, such as chemotherapy, and we are also very skilled in managing those side effects. Palliative care is also a philosophy that is patient-centered. We advocate for you, okay? We'll tell you about different avenues that you can go down. We'll talk about the risks and benefits of treatment versus not treatment. But at the end of the day, we want to do what you want to do, okay? We advocate for you so that you can make informed decisions. And we also look at the big picture, not just the next step in front of you, talking about multiple steps in front of you, months ahead, years ahead, okay? So that's how I look at palliative care as a different sort of philosophy of medicine rather than just treating a number or a lab test, but really looking at the whole person. So case in point, palliative care providers are there for you for whatever journey you're on. Whether you want to be very aggressive with your treatments or whether you want to scale back and say, you know what, maybe I just want to be more comfortable, I want to stay home, palliative care is there for you. So why is palliative care so important? And it's a growing field, and it's really started to take off over the past decade, past 15 years. It actually became its own distinct specialty as recently as, I want to say, 2013. And the reason it's so important is because Americans are living longer than ever before. And a lot of people that live to old age are also experiencing one or more chronic illnesses which may affect their life on a daily basis. This study from the CDC says that by 2050, Americans aged 65 or older will number 89 million people. That's double the number of older adults in 2010. So as our population ages, we are living into longer ages, living into longer lifespans, but we're also having more complex chronic medical problems. And that's why palliative care is becoming super important, and I anticipate that the field will grow even further. So what kind of conditions are seen by palliative care specialists? So palliative care providers, myself included, we typically see people who have advanced or what we call end-stage illnesses or diseases. And what I mean by end stage is meaning that no matter how aggressive they are with their care, no matter how much treatment they get, there is no reversing or coming back from their condition. So we call that end stage. And these conditions have a profound, significant effect on their well-being, their livelihood. It affects them on a daily basis. Their symptoms remind them every single day that they have this condition. It's not simply, oh, I have high blood pressure, I have high cholesterol. This is something that takes up all of their life, and it's something they live with every single day. And these conditions can affect any organ system. We don't, nitpick, oh, well, it affects this organ or it affects that organ. We see conditions that affect any sort of organ, whether that's the heart, the lungs, the nervous system. And we also see patients who have cancer that affect multiple parts of the body, cancers that have spread or what we call metastasize. Okay. So what is an example of palliative care? So I kind of came up with this little vignette to kind of give you an idea about what a palliative care interaction would look like. So let's take, for instance, a 76-year-old female who was recently diagnosed with metastatic cancer. She meets with a medical oncologist, a cancer doctor, to start discussing chemotherapy to treat the cancer. Her oncologist noticed that she's having some pain from the cancer itself, and so she gets referred to a palliative care physician for further management. So at that initial encounter with palliative care, that physician gets to know the patient to get a better understanding of how that condition is affecting them, not just from a physical standpoint, but how is it affecting them emotionally, psychologically, culturally, spiritually? How is it affecting you on a daily basis? We ask about symptoms so that we can treat them and you can have a better quality of life. Okay, we want you to be able to participate in life, to go out and do things, attend weddings, attend birthdays, not be stuck at home in pain, in agony, not able to do the things that you want to do. So that is always my goal for my patients, is to have a better quality of life. Have more good days and less bad days, as I say. We'll also talk about the treatment goals. What do you hope to accomplish on that journey? Do you want to be very aggressive with your care? Do you want every single treatment that's offered to you, procedures, surgeries, being transferred to a different hospital to see specialists who, are very skilled in their specialty? Or do you want to, hey, maybe just scale back a little bit? I'm open to some treatments, but, I draw the line here. So we talk about those things. We talk about your goals, your wishes. What do you hope to accomplish with your care? Another big thing we do is advanced care planning. And the way I describe advanced care planning is that it provides a safety net for what-if scenarios. And I ask my patients to think about these questions when considering advanced care planning. If I could not advocate for myself, what things, what measures would I want done or not done? What quality of life would I find acceptable or not acceptable? Is not being able to communicate acceptable? Is not being able to recognize my friends or family acceptable? These are all things that I try to get my patients to think about. And lastly, if I couldn't communicate, or if I was incapacitated, as we say, who would I want to make decisions for me on my behalf if I couldn't? Okay. So that's a little bit about advanced care planning, and we'll get to that later. So I am a hybrid position at this hospital. So I see people in the hospital, and I also see people out in the hospital, in the clinic. FMC and VVMC are very spoiled, and yet they have an inpatient palliative service who can see people in the hospital. We're here 7 days a week to assist with patients. And the inpatient palliative service is a little bit different than the outpatient palliative service. So the inpatient, these are patients who are acutely ill. Something is going on that required them to be admitted to the hospital. And the inpatient team can add an extra layer of support. They advocate for you. They'll communicate with other doctors. They'll help figure out game plans for you. We can closely treat complex symptoms, give IV medications if need be. We can closely monitor those. And we can clarify treatment goals and wishes with patients and families so that other staff, other doctors can have an idea about what we should do going forward. And we'll talk about different avenues that we can go down, get a better understanding of what you hope to get out of this hospitalization. So palliative care versus hospice. So I have to deal with this question very often. Palliative care, that's like hospice, isn't it? I say, no. Palliative care is not hospice. And I'll explain that. So I describe palliative care as an umbrella. And the umbrella is improving quality of life in the face of serious illness. It's symptom management. It's about allowing you to live your best life possible. Okay. Under that umbrella, you have the philosophy of hospice, which is aggressive symptom management when life expectancy is less than 6 months. And that's if you were to not undergo any more treatment at all. If you just said, I want to be home, I want to be comfortable, I want to be near my dog, that's hospice. It's exclusive focus on maximizing comfort without an expectation of trying to get better or stronger. Whereas palliative care, you can be undergoing treatments, you can get chemotherapy, you can have surgeries, and the palliative care provider is there to support you and manage any symptoms that you may be having at that time. Okay, so some similarities, but overall quite different. So take-home point is that palliative care and curative treatments, they can coexist. They don't have to be mutually exclusive. Okay, you can still undergo your treatments. You can still see a palliative care physician at the same time. However, palliative care physicians do work alongside hospice agencies, and they can help with that transition to hospice if it was desired by the patient or the family. And I wanted to talk a little bit about what hospice is because there are some misconceptions about hospice. So hospice is a service. It's not a location. Okay. I'll talk to patients about hospice. They say, "Oh, I don't want to go to hospice." And I say, "Well, hospice can be delivered anywhere. It's wherever you're comfortable. They'll come to you." Okay. Most people prefer to receive hospice at home in a familiar environment, and hospice can accomplish that. It's a Medicare, Medicaid covered benefit for those with a life expectancy less than 6 months if that person were to no longer want to seek any form of treatment. They just want to stay home. They don't want to come to the hospital. They don't want to see doctors. They just want to be as comfortable as possible. And I think of hospice as an overlooked service because there really are a lot of benefits with hospice that people don't really think about. It's really a great support system. And hospice gives you access to registered nurses, certified nursing assistants. They'll come by several times a week, check in on you, making sure your symptoms are controlled. They'll help with hygiene aspects. You'll have access to social workers, bereavement specialists who can help navigate the next steps. Access to chaplains who come by and see you. Access to a variety of therapists who specialize in massage, music, aromatherapy, things like that to try to promote comfort as much as possible. Hospice also includes access to durable medical equipment, such as hospital beds, bedside commodes, access to medications to promote comfort that are being carefully managed by a licensed physician, and a 24/7 hotline available to call if your symptoms got really difficult to handle. And that's such a overlooked thing, is that hotline, is that if something were to happen at home, instead of reaching for the phone and calling 911, you can call hospice and there'll be a nurse who can walk you through on what to do. So I want to talk about advanced care planning a little more. And this is very vital to our field. At your initial visits and subsequent visits, your palliative care provider will discuss hypothetical what-if scenarios so that you can start thinking about these things and you have a plan in mind. And I always talk about with my patients, I always bring up hypothetical situations. Let's take, for instance, if your condition got worse, what would you want done? Okay, think about that. We always hope for the best. I tell my patients, we always hope for the best. We don't wish bad things upon you. But if things got worse, despite our best efforts, what should we do in that circumstance? So we start thinking about hypothetical situations so that you can have a plan in place about what you should do or your family should do. And the thing is, these conversations might not be as common with other doctors. If you see your primary care physician, they're going to, check some blood work, check your vitals, things like that. But they may not have the time to really sit down and have these difficult conversations with you. And that kind of separates palliative care from other specialties. So advanced care planning. So the definition, it's a process that supports adults at any stage of health in understanding and sharing their personal values, life goals, and preferences regarding future medical care. And I think that's sort of the important point here, is future medical care. Not what's happening right now, but what could happen in the future. How would I want things done? How would I want my care managed in the future? And the goal is to help ensure that people receive medical care that is consistent with their values, goals, and preferences, so that your family, your loved ones know what you want if you couldn't communicate for yourself. So here's some examples of what advanced care planning looks like. So we have medical power of attorneys, medical living wills, and then we also have a code status. So a medical power of attorney. So it's important to ask yourself, if I was in an altered physical or mental state where I couldn't make decisions for myself, for whatever reason, who in my life would I trust to make decisions or advocate on my behalf? Who would have my best interest in mind? Who in my life is familiar with my views and desires on how I want my healthcare managed? So I always strongly advocate to my patients to have somebody documented in your life about who could make decisions for you if you couldn't. Now, if you don't have somebody documented, then it gets a little bit muddy. And by Arizona law, we have to abide by what's called surrogacy. And surrogacy has a certain order. We have next of kin order. And by default, a legally married spouse would be your next of kin, your first person who can make decisions for you. Say, for instance, you were divorced or widowed, then it would fall to the majority of your adult children. If you don't have children, then it would be a parent. If you don't have a parent, then it would be your domestic partner, someone you're engaged with, or you've been in a relationship for a long time and you live together. If there is no one, then it'd be majority of adult siblings. Sometimes it gets a little bit even trickier than that. Sometimes people don't have any one of these. And in that circumstance, we may fall back on a close friend, somebody who knows that person well, knows what kind of person they are. So that can be an instance where we might have to resort to a friend. But overall, it's always recommended to have a documented medical power of attorney, even if your default surrogate is the person you'd want to make decisions for you. And the reason I recommend this is because having a medical power of attorney form done allows you to list multiple people. So say, for instance, we couldn't get a hold of your spouse for whatever reason. We can fall back to a secondary person to communicate with. And at the end of the day, families often make decisions together as a group. A medical power of attorney doesn't put that full responsibility on that person. Okay, they're still allowed to talk with other people, solicit information, things like that. But it's really ideal to have an individual be a point of contact for healthcare professionals to communicate with. Okay. A living will, this is also another aspect of advanced care planning. And this is a document that outlines your medical wishes, and it also provides a framework for your MPOA to work with. Oh, well, they didn't tell me what they wanted in this certain situation. Okay, well, what does the living will say? The living will can help your medical power of attorney make those difficult decisions and potentially ease a little bit of guilt off them. Okay, well, in their living will, they said that they didn't want X, Y, Z done, so I'm going to respect their wishes. And living wills, they often address what quality of life you would find acceptable and the steps that should be taken if that person's health were to not get better or get worse. Living wills might address a terminal condition. If I were to develop a terminal condition, if I were to be in a comatose state where I have no reasonable probability of waking up, what would you want done in that circumstance? So living wills are all about sort of hypothetical situations and the things that you would want done or not done if that were to happen. Lastly is code status. And I bring this up with every patient that I see. I even preface it by saying, I'm sorry, this may seem uncomfortable, but this is something that's important to talk about. And a code status is the measures that we take or don't take in the event of cardiac or respiratory arrest. So what measures would I want to be taken or not taken if my heart were to stop beating or if my lungs were to stop breathing? And the two main code designations are what's called full code, which is full resuscitative efforts, meaning that if my heart were to stop beating, I would want everything done to try to restart it. I would want CPR, which is the pushing on the chest, defibrillation, which is shocking the chest, use of cardiac medications to try to jumpstart the heart, and placement of a breathing tube and being hooked up to a ventilator. I would want all those things done. That's being called a full code. On the opposite end of the spectrum is what's called a do not resuscitate, a DNR, as some people refer it to. And a DNR means that if something were to happen to my heart, just let me be. I don't want all these aggressive measures done. And the reason that some people choose to be a DNR is because what happens after the heart is beating again? I tell my patients, CPR, the things you see in the movies and the TV shows, is not real life. In real life, it's very violent. It can be very traumatic to the body. And the probability of walking out of a hospital the same way that that you were beforehand after a cardiac arrest is about 7%. And so some people say, I want to be do not resuscitate because I don't want to be hooked up to machines. I don't want to put my family in a difficult situation where they have to make a decision to take me off of life support. So by being a do not resuscitate, I'm avoiding that situation entirely. Okay. So every person that gets admitted to the hospital, doctors will always ask about code status. It's clarified, we address it. But out of the hospital, it's kind of free for all. Everyone is presumed a full code unless there is a document done stating otherwise. And what documents am I talking about? So the first document is what's called a pre-hospital medical care directive, or known colloquially as an orange form. Where I came from in Florida, we called it a yellow form, but in Arizona, it's called an orange form. And for those who wish to be a do not resuscitate out of the hospital, at home, out in the community, they would need to have this done, okay? And this is a legal document that instructs first responders to withhold measures in the event of cardiac or respiratory arrest. But the thing is, if this isn't seen by them, then they're going to do everything they can for you. And so I always advocate and I tell people, put this somewhere conspicuous, on a fridge door, a kitchen cabinet. So if something were to happen, the paramedics know not to do anything aggressive in that circumstance. The other one is what's called a PULSE form, and this is sort of a new one, but PULSE stands for Physician Orders for Life-Sustaining Treatment. It's a little more nuanced than the pre-hospital medical care directive, which tends to be sort of all or nothing. So if my heart isn't beating, either do everything or don't do anything at all, okay? The PULSE form, it gets a little bit into the weeds, but it provides information for healthcare professionals, for physicians, on what level of care is acceptable to you in an emergency setting, beyond just cardiac arrest. So say if I was having really bad breathing issues, what things would I want done in that circumstance? My heart is still beating, but I'm not doing too good. What sort of care would I find acceptable or not acceptable? But at the end of the day, it's important to know that these documents are not set in stone. Just because you complete one doesn't mean you're set for life. You can go home and shred it, toss it in the trash. No one's going to care. Code status is very fluid. It can be changed at any moment. And so just because a person completes it doesn't mean that they have to abide by that. Doesn't mean they have to stick with that. And that also applies to medical power of attorneys. Medical power of attorneys can revoke a code status, okay? So case in point, palliative care providers, both in the inpatient and in the outpatient setting, can assist with completing these documents, okay? So overall, in conclusion, palliative care is becoming a larger focus in the healthcare world given our aging population. Palliative care is an extra layer of support for whatever journey you're on. And its goal is to allow you to live your best life possible, to manage your symptoms, to alleviate any aches, pains, issues you're having so that you can live the best life you can, so that you can do the things that you want to do. Right. Any questions?
Go ahead. Yep, go ahead and push the button. Yeah.
Okay. How do you begin to move a patient to find palliative care if they don't even want to have that conversation? If everything indicates that this is the direction we need to go, but they're unwilling to even start the conversation.
Assuming they're already established with palliative care?
No, they haven't been. Like if things medical issues start to go downhill and they will not face the reality of that to even have the conversation, how do you encourage them in the door?
So having conversations with families is always a big thing. How does the family feel about the patient's health? Are they observing things that the patient may not be observing? Are they having less energy, spending more time in bed, eating less? That kind of gives you an insight about what's going on. But at the end of the day, I don't try to push a certain ideology on them. I don't say, hey, you should stop treatment or anything like that. What ends up happening a lot of the times is the patient has to realize it themselves. After undergoing whatever treatment they're doing, they realize that they're not getting better, they're possibly getting worse. They have to have that self-realization. But until that time comes, you can only do so much.
All right. I have a question. You have somebody who maybe is not mentally capable and may have some kind of illness that makes it so that they can't make the decision and they're under the care of somebody else. How does that happen? Let's say somebody is mentally incapacitated in their daily living.
Sure. So we see that quite often, particularly patients who have dementia. And, physically they may be okay, but cognitively they are not able to make decisions for themselves. So we can rely on a surrogate or a medical power of attorney, preferably. In some instances, and I didn't touch on this, but in some instances, if a patient has no one in their life or no one in their life feels comfortable making decisions, then that's when we need to find legal representation for them, particularly through a public fiduciary who can help navigate, make decisions on their behalf. But hopefully we can rely on family members, surrogates, to make decisions for them, and we don't have to resort to a public fiduciary.
Go ahead.
I'm live. Can I slip in two questions? Is that fair or?
Of course.
Okay.
For you, Gary.
The first question is kind of simple and straightforward. How does, you specifically mentioned how hospice interfaces with third-party payments. How does palliative care enter into that world of insurance?
In terms of insurance?
Yeah.
Well, Maggie. Well, it's like seeing any other doctor. It's like seeing your heart doctor or your primary care physician. It is an insurance covered benefit.
Okay. So the second question is, since everybody is just a diagnosis away from the worst day in their life, it would seem that the service you're talking about is needed by everyone. Everyone. I mean, you never know when you're going to have a car accident and have to face whether you want to be resuscitated or not.
Mm-hmm.
Do you see this becoming just life cycle planning that's done in the future?
Yeah. I always advocate for having advanced care documents in place, even if things are going well. You can never be too prepared for when that day may happen, when you wake up and realize that you're diagnosed with something terrible. And it's always a good idea to have these things in place so that you have it documented about what you would want done. I always recommend to have your wishes written down so that other people in your life can know about you, so they know what you want in that certain circumstance. I will say palliative care, it's not necessarily for everyone, because there are a lot of people who can live into old age and not be diagnosed with a terrible condition, a terrible end-stage disease. They may just have some blood pressure issues, some cholesterol issues, maybe some arthritis pains. In that circumstance, I would not say that they are palliative appropriate at that point in time.
My little light here. So to quibble with you, the day you're born, you have a terminal point. You will die. You're mortal. And so you kind of have a little bit of an arbitrary decision that you're describing, where you have a more glaring moment where the probability is against you that you're going to live for too many more years. Do I have this right? Because it seems like palliative care should start from the moment you're born in terms of considering your endpoint and how you want to live your life.
And maybe as the field changes, that will be a different focus. A lot of the patients that I do see in the clinic are what we would consider hospice appropriate if they stopped all treatment. So a lot of patients I see are undergoing some form of treatment, chemotherapy, and I expect that they're going to live months, potentially years. But if they were to stop treatment today, the day that I saw them, then they would most likely be hospice appropriate. So the people that I see in the clinic, they aren't imminently dying. They're not doing too great, but I anticipate that they need a lot of things done to help support them, or else their time with us will be very short.
I've asked Penny. Penny, can you touch on the insurance side of things? I know you have more of an expertise on hospice side of things, but if you can answer a little bit of that in terms of hospice and Medicare, Medicaid, how that all works. Can you? Yep, thank you.
Medicare hospice is a benefit under all Medicare and Medicare Advantage plans. So it's completely 100% covered by the Medicare benefit. And if you have an Advantage plan, you then revert back and traditional Medicare would cover that cost. So that's how it's covered if you're of retirement or Medicare age. If you're under the age of retirement, and still working or something along that nature, then that is covered by most all commercial health insurance plans, Blue Cross and Blue Shield, United Healthcare, those types of things. In the state of Arizona, we have Access, which is our Medicaid program. I also will cover hospice services. Most all insurances will cover hospice services. As far as palliative, I don't know as much about palliative. So the best way to check if you were wondering if your insurance, whatever you do have, covers that, is call that 800 number on your card or go on their website and take a look at that. But most places will provide some level. There might be co-payments or deductibles or things that need to be met, but there usually is some form of support, financial support through your insurance to cover those costs.
Penny.
Go ahead.
This is a sort of legal question, so you may or may not know it. But do living wills and medical powers of attorneys have shelf lives the way regular power of attorneys do?
They do not know.
And it doesn't matter what state they were created in and what state care is.
It does not.
Okay.
It does apply with like an orange form, like in Arizona. That doesn't apply if you go to California or Colorado. It's unique to the state you're in. The Pulse form is more of a national thing, and that's why there's more of a push to standardize, because each state has their own DNR form. And so the Pulse form, the agenda with that is to make it more of a standard thing. So if I have a Pulse form that was completed in Arizona and I go to Alaska, for instance, that's recognized there. I believe the latest data I saw was 46 out of the 50 states currently recognize a Pulse form, but there's more of a push to make it more widespread. But in terms of the medical power of attorney, no, it doesn't have an expiration date. What we do see sometimes is, say a patient did a medical power of attorney form done 30 years ago, and they outlined their wife as their decision maker, but their wife is no longer here. In that circumstance, then we'd have to fall back to the secondary person, or we could ask the person to complete a new one. And if they have multiple medical power of attorneys, which happens sometimes, then you always go by the most recent one that was completed.
So if you have a medical power of attorney and it listed a spouse and your children, but your spouse is gone, that's still a valid.
Correct. So if if your primary decision maker is deceased, then you would default to your secondary. The secondary becomes the primary in that instance.
Great questions. Anybody else? Anyone online have any questions that you may have? All right. Thank you all for coming tonight. We really appreciate you guys coming. It was wonderful to have you here. We are doing these Meet Our Expert Lives series presentations. We have one each month, one here in Flagstaff, and then the next month will be down in Verde, Cottonwood, our campus down there. Next month we have Nancy Payne, who's one of our licensed counselors, who will be talking about, just the emotional support that we need as we go through all and understanding all the life stages that we go through. And so again, it'll be available online, so you can watch virtually or show up in person at the VVMC Cottonwood Medical Center campus. And then the following one in June will be also here. We will be presenting Dr. Payne, Jeremy Payne, who's one of our neurologists, and he's going to be talking about why you probably don't have dementia. So I'm really excited about that one as well. So we have some really great ones lined up over the next couple months. So spread the word, tell your friends, and ladies and gentlemen, have a great night and a safe evening tonight.
Yes, thank you all for coming.